Hello. They have a set up session of various sales by worker. Key challenges for migrant, mobile, and unorganized sectors, workers in accessing health service, social protections, workplace. Please invite the chairperson for business area, Professor Iyer Jani. Please, sir. Mr. Sayyid Mohammed.
It depends on the type of international process. I think even at this conference, as you know, we are supposed to rethink about what changes should take place in the existence. How can we rebuild systems that keep people first and explore answers to ensure that people are together and they rise together in finding ways of development. So my point here is, as few opening remarks which I'm going to present in this session, is as we think about people, we need to ask ourselves whether informal economy workers, which actually mean a daily wage worker, construction worker, a migrant worker, a street vendor, and their likes, how can they access the same health services, social protection, and dignity as anyone else? I'm sure you will all agree that unfortunately at present the answer is no. In this context, this session becomes extremely significant because we are trying to explore challenges faced by informal economy workers, services, social protection, and workplace support. I'm sure you will hear more from the panelists in this opening remarks. Let me just state a few points as my perspective and a various perspective on the issue. Here's what we talk about. Number one, as of now, we have 2 billion people in the population. So 6 out of 10 working hours comes from the informal economy, and therefore it's a number that we should have no matter what policy or organizers are talking about. These are the people who keep cities, markets, farms, households, national economies, enterprises functioning. Yet they remain invisible when it comes to accessing health services, labor, protection, or even jobs and social protection. Therefore, the first point here is that we need to see that services for informal economy workers need to be seen from the perspective of rights and protection. People have human rights, right to access health, right to access social protection, right to access protection from all kinds of exploitation, including violence and when you see like this, you also realize that when rights are ensured and people are protected, they are much more comfortable and the quality of life increases. If you look at social protection, there are huge gaps, particularly when it comes to informal economy workers. The ILO data shows that about 40%, 47% of the world's population is covered by at least one social protection program, which is less than 50%, actually no have access to any one social protection benefit. And 70% working age populations have very little or no effective social protection coverage. So what does this mean? This means for an informal economy worker, be a migrant worker, a construction worker, this means there's no income protection getting works. There's no health insurance, there's no employment benefit, there's no maternity protection, and very limited access to affordable healthcare. Even in countries when services are provided free, like HIV testing and treatment, people in the informal economy find it difficult to access them because for most of them it means loss of daily wages. And therefore, there's a huge opportunity cost for informal economy workers to access public services. And therefore, it's important to take services to them, to workplaces, website, where they spend most of their incomes. And that is why we developed in the IBA program for voluntary transparent testing for workers, in which we took services to workers where they work, to work sites, construction sites, mines, to migrant workers sites where they work, and working through industries, working through civil society organizations, trade unions, and employers. We were able to access and ensure that people start voluntarily accessing HIV services. And this shows that this has the potential of reducing HIV testing gap amongst workers. As of now, even though we are concerned when we see that recent report released by UNAIDS at this conference that new HIV infections are increasing in 3 regions, 3 developed countries. We also see that funding cuts are kind of created a situation of crisis where HIV response has suffered significantly, and there's a chance of resurgence of the epidemic. And therefore, we need to really put our minds together to find solutions to this whole thing and explore not just services but also explore resources. Where can they come from? Untapped resources like Migrant. But there are 2 good things which we have also seen. We have seen that recently we have the UN Political Declaration on HIV and AIDS, which recognizes that ending AIDS requires addressing inequalities. And it is good to know that member states have shown commitment to protecting human rights, eliminating stigma and discrimination, and strengthening community leadership, and also integrating HIV responses within universal health coverage and adopting a people-centered approach. This is a good tool that we have. Member states have shown some time to it, and we need to ensure that we do advocacy, we do mobilize resources, and we work within this framework to take the program forward. Second good thing that we have in front of us is the new Global AIDS Strategy 2026 to 2039, which also calls upon strengthening community-led and inclusive HIV responses, reducing inequalities, and ensuring that rights-based services are accessible in the enhanced community. So, my friends, as I conclude this story, I do not observe that the path to ending AIDS runs through the lives of about 2 million people who are working in the economy. If we leave them behind, we will be able to end AIDS. But we have some examples, some experiences emerging, which you will hear in this conference. And I'm also very happy to note that GAP is planning to develop a white paper based on all the sessions that will be conducted here in this networking Zoom to develop an action plan, some kind of an approach for taking services, HIV services to we know that if we reach them with rights, protection, and services, we can. So we have to find ways to scale up the successful pilots that we have shown in past years, build on them, create new synergies, strengthen partnerships, including partnership with the private sector to ensure that people who work for us have an entitlement and they can access services without fearing discrimination and dignity. And they access services in a way which is convenient for which will keep them from movement. And that is why taking services to people makes sense. That is where workplace and makes programs make sense. I thank you and I look forward to the outcome of mission session. And I am sure that we will have very fruitful discussions, not only was by the panelists, but also by audience who are there and their insights will also be extremely useful. Thank you very much. Good.
Thank you very much, sir. Next, our next speaker is Mr. Loknath Mishra. He is an executive committee member of Indian Network of NGO working on HIV/AIDS and also executive director of Aruna, Odisha, India. So, this sir,
Good morning, friends and two panelists. Welcome to Let's Take It. Friends, I'm Loknath Mishra from India, working with Aruna and Indian Network of NGOs and HIV/AIDS for the last few decades. Friends, I'm really missing the physical participation in the AIDS conference. However, because of the technology made possible for me to participate virtually. Thank you, AIDS conference, the friends participate. The topic given to me is migration. Friends, migration is not new. People have always moved from one place to another from such a language perspective. Migration is seen on across the world. It's not that it is happening in one part, it is happening not happening here or there. It's seen everywhere. The pattern may change, but the main reason remains the same. People move mainly for work and so on. Migration can be divided into three major categories. One is step up learning. People go for a better life from villages to cities, to major cities and other cities, to other countries. But the step making. Second category is transportation. People don't stay in a particular location for a long time. They move with families from one location to another location to very joint village. Third is circular category in circular migrants. In India, millions of people from villages move from villages to cities, move from cities to cities, move from one place to another, move from one state to another. Among them, circular migrants are very important and considered as vulnerable. They are often single member workers who stay away from their family for many months than that. Will their families continue to live in their villages or in the city? Today, I will speak for the challenges faced by the men, more particularly by the circular category of migrants, those who are working in unorganized sector, their access to health services, their access to protection, and their access to supporting. Friends, sometimes they need both here. These are access to patient. Many migrants do not know where to go when they are sick. They not speak the local language. In India, we speak hundreds of different languages, and all are different, not similar to each other. They may second from the may lose when they which is very because of this, majority of the migrants believe that they could be doctor when they are sick, their permission to sick. But it's not health centers. HIV testing, fitness training, counseling, and mental health support are not available at the place of work comes in the midst of the migrants. The second biggest challenge, their vulnerability to HIV and other maladies. Supply migrants always remain away from families for a long time. They may feel lonely and isolated. Some parents take the risk due to peer pressure, due to alcohol consumption, due to liquor awareness, poor access to condom, or counseling services. They got the infection. They got the infection because of ignorance, because of the other risk factors. Additionally, stigma and discrimination is still prevalent, very high belief. Many people are tried to go for HIV testing in fear that they will use that. In place of that, somebody will know that the person is HIV or immediately, that person will be decided from job. So there is legal provisions that you cannot distinguish person from the job because of the HIV infection, but in unorganized sectors, they don't have any paper backup from them. They don't have any legitimate work. They work in daily basis, so within them lose their job. So this makes any treatment and prevention very important. The third challenge is poor living conditions. It is continuing. Many migrant workers live in private rooms, temporary shelters, or in worksites. They may not have clean drinking water, proper toilet facilities, recreation, safe cooking space. These conditions increases the risk of disease. When many people live together in a small space, infection spread easily. Overworking, long working hours, and lack of rest also make their life very difficult, make the health condition worse. The fourth challenge is unsafe work. Many migrant workers work in construction sites, small factories, transport industry, agriculture industries, retail industries, hotels, domestic work, and in many other informal sectors. Often they do not get safety, paid leave, sick leave, or accidental support, or insurance. If they are injured, the immediate consequences, they will lose their job. The long-term consequences, they will lose their livelihood. Many do not have a written contract, so they can difficult to claim their rights. The fifth challenge is the social protection. In India, government is having many social protection schemes, but many migrants cannot easily access those schemes, access the benefit of the schemes because of the identity. The identity card particularly being used, particularly the ration card, the health card, the other identity cards is linked to the native, not to the person. So many people face many, I see many people face problems getting services because of the identity card they are having. The second thing is the language in the office. Third thing is method information, and fourth thing is the complicated paperwork. So benefits do not always reach to the migrants, then they lead it the most. The sixth challenge is the financial insecurity. Most migrants earn daily wages. If they do not work for a day, they may not get paid for that particular day. Additionally, they have to send money to their families for their salary. So migrants have the little savings with them. A small accident, a few days or 1 2 days job loss, or delay in getting the wages, push them into debt. They are almost dependent upon the loan contractor, the employers, upon money lenders. This makes them more vulnerable increases the financial insecurity and their life misery. The seventh point I have identified is the later expected living. Migrants most of the time treated as outsiders. Their contribution is not always significant. But we must remember that migrants build our homes, build our cities, build our hospitals, build our markets, work in our factories. They are the important part of the economy, but they are not being treated with dignity. So these challenges make the life of migrant vulnerable, vulnerable to HIV, vulnerable to infection, vulnerable to many. So what should we do? First thing I would suggest, health services must be made migrant friendly. Services should be reached labor camps, work sites, transport points, and slum areas so that migrants can easily access the healthcare services. HIV testing, counseling, condom supply, TB screening, and general health checkup should be made accessible, easy, and with convenience. So the second point, social protections should be fulfilled. The worker should be able to use whatever identity cards is given to get the benefit of person, to get the benefit of health insurance, and get the benefit of the available skills. Workers must be safer. Employee and contractor should provide safe conditions, fair wages, rest, sick leave, and accidents to all the most important, last point, migrants should be treated with dignity. Migration itself is not a problem. Migration is not something stigmatized. No. The real problem is lack of access, unavailability of services, lack of protection, and lack of support. Let us remember this. Wherever the workers go, their rights, health services, dignity should go with them. They are citizens born with inherited rights. So whenever they are entitled to access all these things and keep the responsibility of the state. If the state, the civil society, the intellectuals can make these things available to migrants, allow them to live with dignity, allow them to get their wages properly, allow them to live with a good health, then they are the most productive population of the nation. So let us decide the entire global migrant population should be safe, informed, and living with respect and dignity. Thank you so much. Thank you.
Thank you very much, Mr. Loknath Mishra. Now, our next session is Mr. M.S. Bakar, former ILO expert in migrant labor rights issue. Please, Mr. M.S. Bakar.
Yes, which ILO supported for at least 5-6 years, I think, in Gujarat, 6 states. And this is focusing, initially this was focused for informal worker and the migrant worker coming from different parts of the India. So intervention was focused on basic services of HIV, basic awareness of HIV, uh, involving migrant workers. And we also introduced the component of sensitizing the stakeholders, the builder associations, and other stakeholders like the Bharti Mazdoor Sangh and other the important stakeholders. So it was welcomed by the industries it was welcomed by the other stakeholders and including the informal workers. Uh, After 2 years of intervention, we also added the component of TB awareness because the HIV and TB problem in India is among the highest burden country as far as TB is concerned. So we included the tuberculosis awareness and district TB officers and state TB officers also involved in this intervention uh, for awareness of worker. And I think after that, a very important component providing social security or adding workers to the different social security platforms, including Ministry of Labor's platform like e-Shram card and Nirman card and various other social protection schemes provided by the state governments like Aadhaar card and that. So it was it is a now complete kind of package, HIV services, TB services, and linking worker is suitable social protection is cards. Our main experiences from this intervention were like we found very interesting data that migrant and informal worker, there is another segment emerging, which is local industrial worker. They are at the same risk of getting HIV and STI. So our data shows that the exact half of the industrial worker, local industrial worker, and another half including the migrant and informal workers. So this was really surprised us. So when NAPO, National AIDS Control Organization, organized a workshop in Delhi to re-strategize reaching out to informal worker. I have shared my experiences from the Gujarat, and they assured us that they will look into it because they are thinking that they are not thinking that the local industrial worker will be at the same risk. This ILO supported intervention, which GAP implemented at field level, uh, resulted very good findings. Another important finding was that the around 70% workers who were getting HIV infection have come from the who are the first time testers. It means that the services were not reaching to them, and it is also very high percentage, more than 70% worker first time tester. Another important observation was that those including those found positive were in their prime age, like 24 to 35 or 37. So this is the prime age group where we find that the workers getting. Although we devised a strategy to contact to different states, ITC, ICTC integrated testing and counseling centers, and refer the worker. Suppose a worker come from Jharkhand, we contacted Jharkhand State Aid Control Society and inform them that if your worker found positive and you should uh, take care of the tracking and the services. Another very important finding was that uh, uh, that women worker, although this was focused on entirely on men, basically 90% of our workers which we found, which we included in this was men, and but 8 to 10% women were also there who were at the risk of getting HIV because we conducted a survey, and in this survey they admitted that their spouses had sexual relationship with outside the marriage. So a promiscuous behavior was noticed, and we also included awareness of worker differentiations for women workers who come along with their husbands in this scheme. Total social protection schemes which we were added workers were very encouraging. More than 3,000 workers included, linked with different social scheme, and they were given a proper card for a particular scheme, and some workers also admitted that they received some kind of facilities which were meant for those schemes, under those schemes. So this was our intervention, and a large number of workers uh, basically wanted that this should continue. And other stakeholder also wanted that this intervention should continue. But due to shortage of fund and other external forces, we were not able to continue this intervention. Although in a concise form, we shared this finding of this intervention to National AIDS Control Organization, and this data regularly feed into the national integrated data of the uh, which NACO has developed. So our data reach to the NACO regularly, and at different levels we wanted to sensitize the national government that intervention for the workers, informal worker, migrant worker, and industrial worker is very important, because we uh, only worked in a very limited area, 6 districts of Gujarat. And among the 6 districts, there was not the entire district. Only after survey, where we, uh, based on the setup of the industries, we around 20 to 25% area of the district. So in this district, we reached to more than 1 lakh of workers, and around 40 to 45 workers form positive, and it means that other workers are at the same pace, because we are reaching very short area. So this means that the intervention needed for the entire district, where we can reach out to informal industrial workers and other workers. So these are the main important things which I wanted to share from my experiences. Another important thing is that syphilis is also part of the NACO, National AIDS Control Organization, to find out the incidence of syphilis among the workers. So through the HIV testing kits and new kit added, which also able to detect the syphilis. So the incidence of syphilis is also among male workers is increasingly rising. We can say that sexual transmitted infection of syphilis is also increasing day by day, we can say. So we also reported this to National AIDS Control Organization that in the Gujarat state incidence of syphilis is also there. So these are the our main findings. First time test more than 70%, and those who are HIV positive coming from the productive age group. Uh, these are the and benefits of social protection schemes, and syphilis is also. And one more important thing is when Corona pandemic break out. So we, after few months of uh, stop of few months, we restart our intervention. So this was the perhaps only intervention in any state where, despite Corona, we started, because building work started in Gujarat. So we also uh, uh, get a kit of awareness regarding Corona. So during Corona, this also continued. These are the few things, because I'm not there from December last year in the ILO. So on the basis of my memory, I'm sharing this experiences. Thank you very much.
Thank you very much for That's Pankaj. Now, next speaker is Dr. Sugata Mukhopadhyay. He is public health advisor of Common People India. So, I request Dr. Sugata, please.
Hello friends, a very warm welcome to this session. I am Dr. Shivago Mukhopadhyay, a public health physician from India, currently associated with Human People to People India, or HPPI, as technical advisor for TB, HIV, and health. HPPI has been working for many years in the health and development sectors across multiple states and districts in India. TB and HIV remain core areas of our work, implemented in partnership with the National TB Elimination Program, National AIDS Control Program, and other development partners. Today, I would like to share HPPI's experiences of integrating TB services into ongoing HIV prevention and care platforms, particularly targeted intervention and link worker scheme projects. The title of my presentation is Connecting Care Model, TB services for the HIV high risk groups and people living with HIV. Now, why is this model important? India's HIV prevention program currently reaches approximately 50.8 million people through targeted intervention, lead worker scheme, opioid substitution therapy centers, and closed setting sites. These populations are not only vulnerable to HIV, many are also at increased risk of tuberculosis. Therefore, existing HIV prevention platforms provide an important opportunity to deliver TB services through low cost or even no additional cost integration. There is already a basic linkage between HIV prevention programs and the National TB Elimination Program to identify people from high risk groups who are diagnosed with tuberculosis and initiate a treatment. This linkage also helps identify people living with HIV who may be affected by tuberculosis. However, HPPI's approach goes beyond TB detection and treatment. Our model focuses on the continuum of care from TB screening and diagnosis to treatment initiation and completion, while also facilitating TB preventive treatment for eligible household contacts and people living with HIV. For this presentation, we drew upon the experiences of four HPPI projects, three targeted intervention projects in Delhi, Unnao in Uttar Pradesh, Kathakota in Telangana, and one link to this scheme project in Haryana. These projects reach diverse populations, including key populations such as female sex workers, men who have sex with men, transgender people, and people who inject drugs. They also covered rich populations like migrant workers and packers, as well as other vulnerable groups. So, how did we integrate TB services? The key principle was simple. We did not create a parallel program. We strengthened the capacity of the existing HIV outreach teams. Community outreach workers were trained to conduct TB symptomatic screening, provide information on TB and HIV during routine outreach sessions, address stigma, and establish referral linkages with the National TB Elimination Program for TB diagnosis, treatment, and prevention. In other words, we integrated TB activities into the routine HIV services using the existing workforce and community platforms. This demonstrated that integration can be practical, sustainable, and highly costly. The results over the 5 years period from 2020 to 2025 were very encouraging. Among HIV high-risk populations, more than 113,000 individuals were screened for TB symptoms. As a result, 671 people with TB were diagnosed and initiated on treatment, and importantly, all successfully completed. In addition, 433 eligible household contacts completed TB preventive treatment, helping to reduce their future risk of developing TB. Among people living with HIV, we screened more than 500 individuals, identified 11 people with TB, and ensured that all were initiated on treatment and completed. Furthermore, more than 300 eligible people living with HIV received and completed TB preventive treatment by our efforts. But the most important lesson is not simply these numbers. It is how these results were achieved. We achieved that without establishing parallel systems or requiring major additional financial resources. By strengthening the skills of the existing frontline workers and integrating TB activities into routine HIV services, we improved access to TB screening, diagnosis, treatment, and prevention. The model demonstrated a comprehensive continuum of care addressing both TB treatment and TB prevention among vulnerable population and TB living. Of course, this success was made possible by the commitment of the project teams. The staff went the extra mile to conduct screening, counseling, referrals, follow-up, treatment adherence support, contact investigation, coordination with the National TB Commission. Another important advantage is that community outreach workforce already have the trust of the vulnerable population itself. They understand the communities, know where people live and work, can reach individuals who may otherwise face barriers due to stigma, discrimination, and limited access to their facilities. Doing this trusted workers provide integrated Indian HIV services. They reduce missed opportunities for early diagnosis and help people access more comprehensive care, the single trusted plan. From HPPS perspective, the cost effectiveness of this approach is also important. We did not establish a separate integrated service delivery system. Instead, we leveraged existing program structures, outreach teams, community relationships, and linkages with government health services. Integration, therefore, became an approach to doing things differently, not necessarily doing more things separately. As India moves towards ending TB and HIV as public health threats, community-based service integration offers a practical opportunity to strengthen both programs and networks. Our experience demonstrates that TB HIV integration and continuum of care are feasible, effective, and scalable. Such integration can improve access to services, strengthen collaboration between programs, increase uptake of TB preventive treatment, support treatment completion, and ultimately save lives. I'd like to end with one simple message. People do not experience TB and HIV separately. Therefore, our health services should not be delivered separately either. If we organize services around the needs of the people rather than around individual diseases, we can provide more comprehensive care, reduce missed opportunity, improve health outcomes, and accelerate progress towards ending both TB and HIV. Thank you very much.
Thank you very much. Dr. Sugar. And thank you very much for your online session viewer on Zoom. May I Pankaj Patel, Project Director on Gujarat AIDS Awareness and Prevention Unit. Thank you very much. Thank you very much.